Good morning, everybody. I see a number of folks are joining right now. It's about a minute before 7, and we're just going to allow a few more people to come on the line before we officially begin. Thanks. Hello, everybody. This is Kathy Bateman speaking to you from Washington State Hospital Association. Thank you so much for joining us this morning for the Maternal Early Warning Signs cohort. This is our third session of this team. You may notice that things look just a little bit different, and the process you used to get onto the webcast was slightly different. We are using a new platform, and it's just slightly different than the one we had before. So thanks for your patience, and I think one of the things you might be hearing is a little ding signal as more people continue to enter the chat box, but we have a few things to work through with our new system, so thanks so much for your patience. So, for this morning, our objectives that we hope to accomplish during our hour together are to review project goal and timeline, to share input of teams from last month's takeaway assignment. We're planning to revisit the importance of standardized communication and then prepare for our PDSA assignment. So this is just another reminder that there are many folks involved in the planning and leadership and support of this cohort. Dr. Lawrence Shields, Dr. Tom Benedetti, Dr. Dale Reisner, and Mara Zabari. And I know that Mara is with us this morning, and Dale is with us this morning, and Tom may be joining us in a little while. I don't think that Dr. Shields will be on this morning, but just want to thank them for all the support for this work. And this is all of you. At this time, we have 14 maternity units represented in this cohort. We're very pleased that all of you are participating at Three Rivers Hospital, Confluence Health, Evergreen Health, Multicare Good Samaritan, Virginia Mason Memorial over in Yakima, our 4 birth centers in the Swedish system, Swedish Ballard, Issaquah, First Hill, and Edmonds, and then our group from CHI Franciscan, which includes the St. Joseph Medical Center, St. Francis Hospital, St. Elizabeth Hospital, Harrison Medical Center, and Highline Medical Center. You all bring a wealth of different perspectives as your settings are varied, and that helps us all understand what the challenges and the opportunities are and makes for better learning. So these are the dates for the 6-session series, and of course we've already done the October 28th and November 22nd session. This morning is December 19th, and we will meet next again on January 20th. As a reminder, all these sessions are 7 a.m. sessions. Hopefully that's still the best time for all of you. There's nothing that's perfect, but this seems to be the timing when most people can set aside an hour to do this work. Timeline. This slide simply outlines our broad plan for the 6 sessions. We had the kickoff in October where Dr. Lawrence Shields was our guest, and he presented a lot of very good information about the maternal early warning tool that was developed down at Dignity. In session 2 last month, we provided an overview, and we reviewed assembling of your teams and helping you start to identify in your units and resources that gave some resources that might help you address any gaps that you're identifying in your settings. This morning, in session 3, we'll do some review of the feedback that you gave following the last session, as well as focus on further identification of resources and ways to help you establish and solidify your structures, such as standardized communication processes that are needed in order to fully implement the maternal early warning signs tool. Next month for session 4, I am really pleased to let you know that Dr. Larry Shields will return to meet with us, and this time he'll be joined by members of his clinical leadership team and some of the individual folks who were directly involved in the work done at Dignity Health in California with their 6 pilot hospitals. And then in February for session 5, we're excited that one of our own teams is going to come and share their story with the rest of us. The team at Evergreen Health has done a great deal of work on this topic, particularly around the process of embedding the tool into the structure of their electronic medical record system. So they'll be with us in February and share their wisdom and experience, and we're looking forward to that. The last session will be held in March, and our focus in that session might be shaped to some degree by how the work progresses for each team, but the broad idea is we want to support your ability to continue to work toward a stronger structure and a plan to fully implement the standard processes that will help capture morbidity before it becomes severe, and the ultimate goal, of course, is to decrease maternal mortality. So speaking of goals, this is our goal for the cohort. We want to reduce severe maternal morbidity and mortality by improving timely identification and response to triggers that may be associated with deteriorating maternal status during pregnancy and postpartum. Broken down into our objectives, our work will include education. We want to educate staff and providers about early signs and symptoms and the ability to impact outcomes of common maternal morbidities, including hemorrhage, preeclampsia, sepsis, and cardiovascular compromise. We want to establish unit structure in the form of policy, so ensure specific policies are in place for postpartum hemorrhage and preeclampsia hypertension, which include early diagnosis and management. We want to adopt the use of clinical tools, so implement the maternal early warning trigger tool within each team's maternity unit to improve early identification and rapid response to deteriorating maternal condition. So this slide reviews with you how to begin working with the maternal early warning tool. The approach here is to simplify what we focus on initially to try to avoid being overwhelmed by the entire algorithm, which is a fairly complex document when you look at the whole thing. The piece of the algorithm that you don't see in the simplified version is the detailed care guidance for managing situations where criteria for positive persistent triggers are met. A key point to recognize here is that when triggers are persistent, the next action is to request provider bedside evaluation and anticipate the need, as well as requesting that immediate or urgent provider bedside evaluation, is to anticipate the next steps, the possible need for evaluation of critical care or moving the patient to a higher level of care. So as you might recall as well, the tool is designed to guide the care based on 4 pathways. So those pathways are infection or sepsis, cardiopulmonary pathway, hypertension, preeclampsia pathway, and then obstetrical hemorrhage. So last month we talked about the toolkits available through the California Maternal Quality Care Collaborative. They have toolkits available at this time for hemorrhage and preeclampsia. they are also expecting to make at least one additional toolkit available quite soon that will help address care for the cardiopulmonary pathway of the algorithm. So keep checking back on that website. I've provided the link for you here on the slide. The toolkits are free. The process to access them is very easy. It requires just a brief registration process, and that will then allow you to download all their materials. There's really so much useful practical information on that site, and it's set up in a way that you can just translate it right into your own facilities, procedures, and processes. So I definitely encourage you to get familiar with what's there. So we did some polling last time, and I just wanted to take a few minutes to kind of go over the sort of the theme of the feedback. So we asked, to what extent do you agree with this statement? We utilize standardized order sets that specifically delineate expectation to notify providers when patient vital signs fall outside established parameters. So as you can see, there was a fair number of folks who didn't answer. Perhaps you felt like one person was replying on behalf of each of your teams, so that's why maybe the results look like this. But you know, there was not much of a response that indicated you were firmly and absolutely convinced. Just 2 out of 18 people responded that way. Another 6 thought that maybe there were, so you weren't quite as confident. And then we asked, to what extent do you agree with this statement? Oh, I think I'm on the wrong one here. Okay, there we go. Clinicians, nurses, and doctors will appreciate use of the maternal early warning signs tool because they will understand that it improves our ability to recognize and respond in a timely way to patients who may need urgent attention. Here, 3 of you were absolutely confident about this, and another 6 thought, you know, maybe, not quite sure, but relatively or somewhat optimistic about it. And again, about the same number of folks didn't reply to the polling questions for each of the questions. To what extent do you agree with this statement? How confident are you that staff and providers in your unit are accustomed to using standardized tools such as the maternal early warning tool and will readily adopt it as it is introduced? So it was good to hear that 4 of you were absolutely confident about this, and another 4 thought that maybe people would be enthusiastic, and then a number of you who didn't know or didn't answer. Now, let me just pause here for a second because I didn't mention it, but even with our new platform here, it should look pretty much the same to you. We still have a chat box. You are still welcome to type in any questions or feedback or input you might have for me in the chat box. We did mute all of you upon your entry into the webcast, but if you would like to make a comment or ask a question at any point, you can still use the little hand raise icon, and we will see that you want to speak. So I just want to make sure that folks know you can interact with us in that way. So I want to give everyone a big, huge kudos here. Every team responded with turning in feedback on the takeaway assignment. So I'm really impressed with the responsiveness and the commitment of all of you on your participation in the work. So thank you so much. Your input is what really makes a cohort like this have value, so we definitely appreciate it. So this is just a reminder of the questions that were posed for our takeaway assignment last month. And I am really pleased this morning to be able to introduce you to one of our cohort participants. Van Chimtom is a clinical nurse educator at the Family Birth Center at Highline Medical Center, Highline being part of the CHI Franciscan Health System. Van's offered to share with the group her perspective on the situation at Highline with respect to those questions. So what I'm going to do is just unmute Vanna's line here, and we'll go through these questions one by one, and she's going to share the perspective from there at Highline. Van, say hello if you can be heard. All right, a little bit of a technical difficulty. The system wants Van to do something else before it will allow her to be unmuted. So I'm going to let Cindy, our support here, work on getting Van unmuted so that we can talk to her.
Well, it's because she's not online properly.
So
can't be unmuted until they enter their PIN number.
Okay, so I tell you what, Van, I know that you're on, and perhaps perhaps we can just do this with, I wonder if you entered your answers in the chat box, if I could give them for you. And I know you're chatting me that you're here on the line, so I appreciate that. The first question was, do we have a protocol for obstetric hemorrhage? So, you know, this may, and Van is answering that yes, you do. I think it might be a little bit more valuable if we could have a conversation with Van. So I think what I'm going to do is go on, and if Cindy's able to connect with Van and get her on so that she can actually speak to us, that'd be great. And if not, we'll just move forward. So let me share with you a bit more on what the teams as a whole had to say. All the teams said, yes, we have a hemorrhage protocol. One of the comments made here was, we have this in place, but we could make it more visible. We are incorporating the process into our emergency staff drills. I thought that was a representative comment of what I heard from many of you. You obviously all have a protocol in place. Some teams were very confident that the protocol is fully embedded in your processes and used routinely whenever you have a serious hemorrhage, and that you have a structure in place where you regularly educate to that and practice it. And then that's the positive end of the spectrum. On the other end of the spectrum, some folks were feeling like, yes, we have a protocol, but we need to review it, we need to practice it with our teams, and we're not sure that everybody really understands and is ready to do their part to fulfill their role in a hemorrhage situation. Similarly, with respect to preeclampsia, all but one of the teams said, yes, we have a preeclampsia protocol. Kind of a little bit ambivalent with respect to whether the protocol is embedded in processes. One person said, no, in general, yes, but ongoing RN education is necessary as staff turns over. Not recognized elsewhere in the organization as an emergency for the pregnant or postpartum patient, can be minimized at times. I think it's likely that everybody can relate to that. I know that sometimes the blood pressures that we see in preeclampsia don't always make the same kind of impression on folks in the ER or critical care that they do on our OB teams, and sometimes we're not exactly having a shared mental model when we're talking about patients like this. In terms of the rapid response process being accessible to maternity patients, you all said yes, it's accessible. There was kind of a but here in terms of how you felt about that. A couple comments. Debrief participation is good. However, there's an advantage to an OB rapid response. The intensivist does not necessarily understand the hematologic changes in a pregnant and postpartum woman. Sort of a follow-up on the preeclampsia issue, the same kind of challenge. Another person said, we have an internal code alarm for LDRP, an internal code button for NICU, and a house-wide rapid response and code blue response team. So that sounds like a place where they have their rapid response process pretty well delineated. But then another person said house-wide rapid response process and not specific to maternity. This is only provided by ICU RNs. So the takeaway from all of your comments here was that yes, you have it, and it is of varying value in the obstetric setting, and some of you are feeling like that you have work to do to make it valuable there for your maternity unit patients. This one was a little bit different. Do you have an established communication process policy for abnormal vital signs? Much more of a mixed answer here. 9 teams said yes, 4 teams said no. And I know 9 and 4 adds up to 13, and there are 14 teams. And all 14 of you did provide me your feedback. It's just that the slides were finalized before I received the last one. But the last person's feedback was aligned with the others. So here some comments here. There are orders in EPIC that outline limits to notify the provider for. There is not a systematic process that RNs follow when documenting that they reported any abnormal vital signs. For example, put in a progress note, document in doc flow sheet. There is a variation in practice. Another person said, no, there are no triggers outside of the built-in high or low flags in EPIC. No outline process for calling provider when XYZ happens. So as I looked at the differences between the responses to this question versus the other, it did seem that there was a concern for sure that the communication processes and policies needed further development and strengthening, and that the issue of documentation in the electronic medical record was a significant variable here. So from that, I took away that perhaps that's where we should concentrate a little bit more of our effort for this morning. And I did want to call to your attention this particular journal article. Several of you brought up the topic of your electronic medical record and how vital sign documentation becomes part of the process. So you may find this article very interesting and helpful. It describes a study that was conducted on a cohort of women who have been affected by postpartum hemorrhage, and it uses the vital sign alert system that was embedded in an electronic medical record. In this particular study, that was an EPIC EMR. And the tool they developed, they called the OBVSA, or Obstetric Vital Sign Alert. The results of this particular study demonstrated a reduced time from symptom identification to response time, and a reduced time from symptom identification to intervention time. So the article may be of particular interest since it focuses on implementation of this tool in an actual clinical care environment. I have put the reference on here for your information there at the bottom of the slide. As always, we will be making both the recording of this session and the slides available to you afterward, and we'll work to be sure that we get this out to you, so those members of your teams who couldn't participate this morning. I know it is the week leading up to Christmas, and I'm presuming there's some extra folks out or on vacation, so we'll make the presentation available so you can get it out to the rest of your team. So I know this slide has a lot on it, but I thought it was a familiar model to everybody, the Swiss cheese model that was introduced 25 plus years ago. But this version shows an example of communication in the obstetric environment. I think it's really a reminder of the critical nature of team communication in order to recognize and intervene early when a patient's condition might be deteriorating, as well as to recognize risk when there are gaps in our communication processes. Nurse recognition of an abnormal vital sign and effective communication of those vital signs and the clinical condition to the appropriate provider really has a very direct influence on the patient's ultimate outcome. I think as you take a look at the slide, you can see all the points of potential failure. The failure to create a shared mental model, that situational awareness where everybody's sort of working off the same page. Failure to communicate changes in the mom's condition. Failure to really appreciate the significance of a subtle vital sign change. Failure to relate the symptoms to the patient's overall condition. Failure to SBAR, failure for safety, and failure to educate, big ones there. And then a failure to question assumptions and sort of continue along the same erroneous pathway without really evaluating critically. And all of that ends up in a failure to make a correct and timely diagnosis, and ultimately an outcome that threatens maternal outcomes with increased morbidity and mortality in some rare cases as well. So I think one of the things that was brought to our attention within the CMQCC preeclampsia toolkit was the importance of effective communication and teamwork as essential components of obstetric safety and quality. Their point is that communication breakdowns and failures of organizational culture and teamwork have consistently ranked among the top 3 leading contributors to reported maternal and newborn sentinel events. And while it is difficult to link specific discrete communication strategies to changes in patient outcomes, there's evidence that sustained attention to communication, teamwork, and safety can indeed improve perinatal outcomes. The 7 U.S. professional organizations for clinicians who care for childbearing women assert that shared decision-making, effective communication, and effective teamwork are fundamental tenets of quality patient care. These principles are really especially important in the setting of maternity complications such as preeclampsia and eclampsia, where the potential for catastrophic problems is elevated and early identification and communication of disease progression is essential for effective management. So this slide shows the vital sign criteria from the maternal early warning tool developed at Dignity Health. So just to go over this again, based on the work by Dr. Shields and his team, specific criteria were identified that when present should elicit urgent provider notification. So please recall that for the criteria listed on the left of the slide, 2 of the vital sign criteria should be met and should be considered persistent, in other words, still present when repeated 15 to 20 minutes later, in order to be considered a positive trigger screen. For the criteria listed on the right side of the slide, presence of just 1 persistent abnormal value will signal a positive screen. So if your oxygen saturation is less than 90, your respiratory rate is greater than 30 or less than 12, your heart rate is greater than 130, your MAP is less than 55, or the nurse is clinically uncomfortable with the patient's status, the presence of just 1 of those triggers signals a positive screen. So this is a familiar model, of course, but I thought it was worth our review for a couple minutes. The SBAR format was developed by Kaiser Permanente. It was originally adapted from military and aviation crew resource management practice. It's been recommended and taught in most healthcare teamwork improvement programs. So in the SBAR format, situation, background, assessment, recommendation, the person giving the SBAR provides a brief, organized, predictable flow of information that facilitates critical thinking and communication between the healthcare providers. It might be especially helpful to level communication styles between disciplines, which is the circumstance we have when we work with the MEWS tool. So in that context of working with the MEWS tool, nurse recognition of abnormal vital signs and effective communication of the vital signs to the appropriate provider has a direct influence on the direction and timing of how the care proceeds. So SBAR is certainly a familiar concept, but the reality is that in actual clinical practice, I think we have to recognize that it's not always done effectively. I do like the fact that this particular example tool uses very specific language for how to express clinical symptoms and impressions very succinctly and clearly. such as in the situation, the person says, I'm concerned about the blood pressure because it is over 200 or whatever it is, because the pulse is over 140, less than 50, or exactly stating the situation. And of course, you don't talk about the entire patient's history and physical in your background. You tailor it so that you're speaking to the background data that is appropriate to the situation. Sometimes the A in SBAR is the most challenging one for nurses to express. I think these example statements here in this model make it possible for a nurse to position his or her statement of the assessment in a given particular patient situation in a way that he or she is comfortable stating it. So it's okay to say, I am not sure what the problem is, but the patient is deteriorating. The patient seems to be unstable and maybe getting worse. We need to do something. So I think sometimes nurses get tangled up in the fact that they should have to make some sort of a medical diagnosis, and that's not what SBAR is meant to do. Another thing is, as is pointed out in the trigger tool, a nurse who is clinically uncomfortable with patient status, when that is present, it should be considered a positive trigger. So I think when that situation occurs, the A and the R in SBAR are the obvious points to make that declaration clear. And they should follow conveying of relevant situation and background information. So this example tool is particularly useful, really, because it gives clear examples of exact wording that can be incorporated into real patient scenarios. If any of you want to be provided with an electronic copy of this tool, I'd be happy to share it. So just let me know. It comes from Kaiser Permanente. I found this expanded SBAR format, and it's referred to as SBAR plus RR. So it adds both reasoning and ratification to the R for recommendation. This one's found in the CMQCC toolkit, and I wanted to share it with you too. So what I found helpful about this one is that this tool adds the importance of preparation for an SBAR. So in order to deliver an effective SBAR, you need to assess the patient, review the recent notes and lab results, and have your medical record available during the conversation. Those seem like basics to those of us in leadership, but it's amazing how often that doesn't necessarily happen in real patient situations. What's added here is the reasoning to ensure team members understand each other's interpretation of the present situation if immediate agreement is not reached, and also ratification to ensure that team members have an agreed upon plan for moving forward. So if you look at the reasoning section, the toolkit indicates if the response is not what you expect and requested, state why. What you think should happen is important. What could happen if we don't do this? And then the ratification is to close the loop by confirming actions to be taken. Assure mutual agreement on the plan. So I just have a little bit of a scenario example here to demonstrate the closed communication loop. I'm going to try to play the part of two people here just to provide this example. The nurse says, and this comes from the toolkit, so this isn't the words the way I would use them, but this is how the toolkit put it. Hi, CNM Jones. This is Nurse Smith calling about Ms. Green in room 427 in XYZ Birth Center. She is a 39 3/7 weeks, G1, P0, admitted for nausea and vomiting this morning. Her blood pressure is 150/92, no proteinuria on DIP UA, but she has a sudden severe headache. I'm concerned, and I would like you to come over now to evaluate her. Thanks, Nurse Smith. I'm going to be over later to rupture her membranes and get this labor going. She must be miserable from all that vomiting. She probably has the flu. I understand the vomiting could be a GI bug, but I'm concerned that the vital signs and symptoms Ms. Green is demonstrating could also be atypical preeclampsia. And if so, the headache would make it severe preeclampsia. I really think she needs a workup now, and you should come over to evaluate her. When can I expect to see you? Oh, I see. Well, please draw XYZ labs right away. I'll be right over, and I'm calling the OB back up now. Thanks for clarifying your concerns. Okay, great. I'll draw X, Y, and Z labs right away, and I'll let Ms. Green know you'll be in to see her in about 15 minutes. Agreed. Thank you. So I think that they were able to change the course of the conversation by persisting a little bit to describe the level of concern, and that ended up changing the plan of care pretty significantly. So I just wanted to provide you another potential resource for places you can get additional tools like PowerPoints that include facilitator notes, checklist tools, even video examples, all about implementing teamwork and communication in your settings. It comes from AHRQ, which is the Agency for Healthcare Research and Quality, and it's under the Comprehensive Unit-Based Safety Program. There are lots of resources in this toolkit. Similarly to CMQCC, the tools are free. It requires only a very simple registration process. The link to get to this is on your slide, and it will take you to the place where you can download all the materials that you wish to use, and it's very, very valuable. I would recommend that you check this one out too. Okay, so let's take a few minutes to talk about the next steps for this upcoming month. But before I do that, I'm just going to let you know that although we couldn't make a direct connection with Van, I want to say that I appreciated she and Denise Mabou, Van's manager, their willingness to share their experience at Highline. And one of the reasons I asked her to speak is that Van has done a great deal of work to work on these issues at Highline and help the teamwork process there be strong. And I think that team is a great addition to our culture cohort work. So thanks, Van, and we'll work through the bugs here so that we can communicate better with one another next time. All right, on to next steps. This is our assignment for this upcoming month. Our purpose here is to conduct a small test screening patients using the standardized maternal early warning trigger criteria. So what I'm asking you to do at each of your birth center sites is to identify 5 nurses who are willing to participate in the test at each birth center. Okay, and then we want each of the 5 nurses to screen one patient at least twice during a given shift when they're working on this test to identify the presence or absence of any positive triggers. And also, if any patients are screened positive, to identify the time period in which the provider received, or in which the patient received provider evaluation. So, it looks like we didn't, what we did was decide that it being Christmas, we needed to give you a bit more time on this assignment. So I know the slide there says January 6th, but we think that another week might be helpful to you and is workable. So consider the due date January 13th. The how here is a data collection tool for use by each nurse participating in the test is going to be provided to you, and a data collection summary form that one of you from each team will return to us will also be provided. So this is a little bit of a taste of what the data collection tool will look like. So I've included just that little graphic that shows the vital sign criteria for where triggers are elicited, so that the nurse who's working with the data collection sheet will have that for a quick, easy reference. And all the person needs to do is use those criteria to screen one particular patient at least twice during a given shift. And then the summary form is going to be used by each leader, one leader at each site, to complete and return to us by that January 13th date. So to summarize, I'll send you a data collection tool and a data collection summary form by email after this webcast. You need to identify 5 nurses at your site who are willing to participate and do the test. And then you simply return one data collection summary form to me, and my email is on the slide. And we would like you to return that by Friday, January 13th in the new year. So before we go on, I'm just going to take a minute to look at the chat box here, because I think we've gotten a little bit of feedback. One person has shared, when implementing the SBAR, we need to acknowledge that power differences of the professional hierarchy can, in certain settings, create significant barriers to carrying it out effectively. It is helpful to have conversations about this. I think the work that has been done, and many of you are participating in the maternity unit culture, you're learning a lot about some of the ways in which the relationships between people certainly impact our communication and how effective it is and how clear it is and how well we understand one another. I have a request in the chat box to send this by email with the correct due date. Yes, we will correct the due date so you know when we're asking for it. All right, it sounds like we maybe had a 1 or 2 minute break in our audio, so I apologize for that. Otherwise, I am not seeing any other comments in the chat box. If anybody wants to be unmuted in order to ask a question directly, now would be a good time for you to raise your hand. While you're thinking about whether you have a question, I'm going to just put this slide up again that reminds you to mark your calendars for our next meeting on January 20th, where we will gather together again. And let me just I don't see any more questions popping up. So I am just going to close by wishing you all a very blessed and happy holiday season here with the holidays right up against us here, and wish you a great day, and thank you again for participating this morning. Bye now.